Welcome to ICU Primary Prepcast. Hi, my name is Swapnil, and I'm joined by my co-host, as usual, Dr. Mike Clifford from Melbourne. So welcome, Mike.
Thank you, Swapnil.
I hope the things in Victoria are getting better while Sydney is getting hot.
Finally. Not finally for you, finally we're in the clear. Yeah.
That's right, for a change. So today we are going to do slightly different approach towards the primary exam. As Mike suggested last time, we are going to discuss a bedside scenario, and Mike is going to demonstrate how we can use this scenario to practice primary exam preparation in your day-to-day life. And I'm going to be Mike's consultant for a change, and I'm very happy with that because Mike is going to be my junior, and Mike is going to walk us through one monitor, one drug, and one physiological question. So are you ready, Mike?
Yeah. So I think it's important that primary candidates realise that the best place to learn the primary syllabus is at the bedside, and that it's all there for you. And if you have a discussion with your consultants at the start of the day and just ask them, look, can you ask me just one question on every patient? And if they ask you one physiology question or one pharmacology question or one other question that's to do with the syllabus, it's a very easy way of walking around the ward round and just practicing your Viva technique and searching out what you don't know about topics, and just to keep things rolling. It's just another way of providing you with an opportunity for revision in the lead up to the exam.
Yeah, that's correct. So let's start with the scenario.
Okay.
It's a very common scenario that ICU will have a 42-year-old male patient admitted with pneumonia and septic shock. And currently he's intubated and ventilated. The ventilator settings are he's on SIMV with a standard 6 to 8 mils per kilogram tidal volume with a PEEP of 10. And he is sedated with fentanyl and Midazolam infusion. And he's on some vasopressors as well. So first of all, we're going to discuss about the monitor. So every single patient in similar situation will have arterial line. So Mike, can you please walk us through what is the underlying physics principle for arterial line or invasive blood pressure monitoring?
Okay, sure. So that's a good one. So I'm standing at the bedside and I'm looking over at something that I see every day, and I see a number on the screen, and I've got a measured pressure. And each of these monitors will have a physical principle. They'll have some componentry to discuss and waveforms, and then we can talk about some of the problems. So if I'm looking at the arterial line, I can see that the principle here is a conversion of pressure in the patient to an electrical signal on the monitor. And what I can see is tubing connecting the patient's arterial line or radial artery to what's essentially a transducer, which is sitting at a point relative to the patient's sort of position in the bed. And that comes back to sort of zeroing and level. So the components of it are a piece of short, stiff tubing to maximise the transfer of the information in the arterial waveform to the transducer with minimal loss of wave information. And then there's essentially a Wheatstone bridge connection of little silicone crystals. And that's the same in any invasive pressure monitoring system, but in this case, we're talking about arterial waveforms. And then that will be converted into waveforms that are subsequently put through various filters to remove some of the signal abnormalities. So the short, stiff tubing is there to optimize the transfer of the harmonics of the waveform. As we know, any sort of arterial waveform is made up of a sine wave or multiple components of that sine wave, and they can be sort of taken apart and analysed via Fourier transformation to find an underlying sine wave. And that primary wave is what you're trying to optimise. Now, if you've got too much oscillation in that system, if your tubing is such that it wobbles with the arterial pulse, you'll have an underdamped trace and you'll have excessive movement. And you often see that when you put an arterial line in an elderly patient with a very stiff arterial system, you'll see this very high peaked wave that is a little bit underdamped. And similarly, if you've got other things in the system like air bubbles or blood clot, that can cause damping, so your waveform's not as true. So the system is calibrated around a a wave rate that occurs at a 60 beats per minute or thereabouts, and also the underlying frequency waveform within that, so that it can transfer all of that information. So what we're trying to talk about is the resonance of the system, and you want a system that will enable an appropriate amount of damping. And we talk about optimal damping, which is if the transducer is oscillated from its baseline, it will have a waveform above and below the baseline and then come back to normal within 1 to 2 waves. And that's got a damping coefficient of about 0.64. So you lose about 2/3 of your energy on each wave sweep, if you like, is a simple way of thinking about it. You can have underdamping, where the waveform goes on oscillating for far too long, or overdamping, where you don't get adequate wave signal above and below the baseline. The waveform is flattened. And the resonance you're looking for is the resonant frequency of the system. So that plastic tubing that you've got connected, if I tap it and I could listen to it, I would hear a vibration tone that would ring in the same way a guitar string rings or a piece of metal rings when you tap it. That's the natural frequency of that material. And that will go on ringing and making a noise. So that's obviously, we don't want that to occur. If we're trying to measure something, we want to dampen that resonant frequency. So that pressure signal is converted from the blood phase into the saline or heparinized saline containing catheter system. And that then travels along to a small, in the olden days, a little metal plate, but more modern systems have a silicone crystal. And as you deform that crystal with each pulse beat, it changes the resistance within the crystal. That's the piezoelectric effect. So we deform that crystal, changes its resistance, and that alters the current flow through a system called the Wheatstone bridge. Now, the Wheatstone bridge is a very old system of providing a balanced resistance across a voltmeter. So you've got a voltage source. In this case, the current source is the power mains producing current flow, and that enables the resistance to be calibrated to the 0 point. And the way we do that is we turn the transducer to atmosphere, and we let the bridge come to balance at that point. And every bridge will be balanced at a slightly different amount of respiratory leakage. Each individual transducer is therefore zeroed. So we turn it to atmosphere, and we tell the computer system that this is atmosphere, and we have a preformed algorithm within the computer system that knows that atmosphere and therefore 0 will be displayed on the monitoring system. And then we can turn back our transducer tap so that the little piezoelectric crystal is no longer just seeing atmosphere and the bridge is therefore balanced. It's now seeing the pressure wave coming to it from the patient. And that pressure wave hits the piezoelectric crystal, deforms it, changes its resistance. So now the Wheatstone bridge is out of balance and there will be current flow across it. And that's detected by your little voltmeter. And the amount of current that flows is proportional to the resistance change, and that's displayed on the screen as a waveform going up or down. And that's just simply what the monitor does to that information. So you've set a 0 point, and it knows that if I've got so much resistance change and therefore so much current leak, that must be a blood pressure of 120. So that's the number it displays on the screen. And as the pressure falls to the diastolic level, you get less pushing on the piezoelectric crystal, so the resistance is less change, so there's less voltage flow. So the monitor says, oh, okay, your systolic blood pressure is 70. So there's this instantaneous change that follows at beat-to-beat levels. Now, the position of the overall system relative to the patient is the height of the transducer, and that doesn't affect the 0 point. The 0 is atmosphere, and it's 0 at the ceiling and it's 0 at the floor. But if you want the 120/80 to be reflective of the patient's blood pressure in the body, then you have to have your transducer sitting at the level of the right atrium or the phlebistatic axis. So then you know that your perfusion pressure from that point is 120/80. If the patient's lying in bed at 45 degrees. Now, if they were a head injured patient and you wanted to optimize your perfusion pressure at the circle of Willis, well, then you'll move your transducer upwards towards the external auditory meatus, and you'll monitor pressure from that point. You don't need to necessarily re-zero or change the 0 because it's still measuring 0 at atmosphere. All you've done is change the hydraulic height of the transducer so that is now where it measures your pressure. So you can test this out for yourself at the bedside. If you pick up the transducer that's monitoring, lift it up in the air, you'll see the blood pressure go down. And if you drop the transducer down, you'll see the blood pressure go up. Now, the blood pressure in the patient isn't changing. All that's happening is that the pressure measured relative to the gravitational height or hydrostatic height is changing. Your 0 point hasn't changed. If you turn the tap to 0 at each of those points, it would still read 0 because atmospheric pressure really doesn't change over the 1 or 2 floors of a hospital building. So you don't have to re-zero your transducer. So that's how your arterial pressure is determined. That's some of the characteristics of it that you would see. And then you would look up at the screen, you'd see the patient's blood pressure being determined.
Thanks, Mike. That's a very good candidate who can answer that much about arterial pressure waveform. Obviously, that's a medical candidate answer. And I will be employing this candidate in my ICU as a senior registrar straight away from next year. So well done. So what we're going to discuss is now the clinical application. So let's say this patient is on PEEP of 10. He started becoming more hypoxic and consultant decides to increase the PEEP from 10 to 15. So what will be the physiological effect of increasing PEEP on this patient?
Okay. That's a very good question, Swapnil, and it's almost certainly why you've asked it. And it's not an easy question to answer. The answer to what are the effects of a change in PEEP are always, well, it depends, okay? Because it depends on the underlying state of the patient's cardiovascular system, and in particular, the underlying capacitance of the venous system and the nature of the filling of the right and left atrium. So if you just think simplistically, if I put someone from, say, 5 of PEEP up to 15 of PEEP, the instantaneous effect of that will be to increase the intrathoracic pressure. And that will have two disparate effects on ventricular filling. It will cause a reduction in venous return to the right heart because the venous pressure is instantaneously reduced to the right heart. So the right atrium effectively gets less venous return. So the right ventricle gets less venous return. So the cardiac output from the right side reduces. Simultaneously, the left atrium is filled with blood that is being emptied from the pulmonary veins into the left atrium by that increased thoracic pressure. So the left atrium sees an increase in preload. The left ventricle gets an increase in left ventricular and diastolic volume and pressure and will increase the left ventricular output. At the same time, the afterload, if you like, on those ventricles is also moving in the opposite direction. So the right ventricle sees an increase in pressure that it has to eject into. So the right ventricular afterload increases, whereas the left ventricle, which is ejecting into the aortic root and then outside the chest, sees a reduction in what's called the transmural pressure. So you've gone from a lower difference between your intracavity left ventricular pressure and your external pressure in the thorax from +5 to +15. So the effective afterload is reduced. So the transmural pressure is reduced. If you think about it, the left ventricle is contracting at the same time that the pleural pressure is squeezing. So the left ventricle gets an assist and that reduces the left ventricular afterload. So you may see a small increase in left ventricular output. Now, the overall effect after a few heartbeats will probably be more dependent on the effects on the right side of the heart, because whilst that initial change improves left ventricular output, left ventricular afterload, you still have to have adequate venous return to fill the next few heartbeats. So what you often see in a patient is a reduction in cardiac output and therefore blood pressure. Now, the reality is that what happens is that the body responds to that change and starts to provide reflexes that improve the situation. So there'll be a sensing of that overall reduction in cardiac output over the next several heartbeats that will cause some vasoconstriction and cardio acceleration, assuming the patient has a sympathetic nervous system that's functioning, and the patient will go back to baseline, if you like, and improve their cardiac output. Now, we often don't wait for that to occur in ICU. We see the effect of the PEEP, and over the next couple of minutes, looking at the low blood pressure, we'll say, can you give some fluid? And what we're doing is we're filling up the venous capacitance side of the circulation to await that sympathetic nervous system return, if you like, and then put the patient back to where they were. Because if the patient had a cardiac output of, say, 7 litres a minute in the case of this patient with septic shock, and you've suddenly reduced it, well, their body will respond until they've got 7 litres of cardiac output again. They'll go back to where they were. Or we have to pharmacologically do that for them, whether it's by giving fluid or increasing their vaso or venoconstrictors or giving them some more inotropy. We'll put them back to the same level of cardiac output we wanted. So the effects of PEEP are somewhat complex, and it depends which side of the heart you're talking about and what your baseline state is. The other thing to mention is that that sometimes an increase in PEEP will improve your pulmonary vascular resistance because it might improve your lung volume and improve your pulmonary arterial system, either by recruiting arteries and or opening up airways and improving ventilation. So it may well improve your pulmonary vascular resistance, reducing it and enabling more cardiac output from the right ventricle. But most of the time, your patients are relatively stable and reasonably well recruited on the ventilator. You're not going to get a marked change in pulmonary vascular resistance, but it's possible. So there may be an effect to improve right ventricular output in the short term too. So the effects of PEEP are quite complex. And this is one of the reasons why the CICM exam, we keep asking about it, because we want people to try and explore that complexity. We often talk about one ventricle or another, but the overall effects are dependent on the patient's pre-existing state, particularly their volume state and their inotropic state, and whether or not they've got some cardiac dysfunction or not. And the changes that occur in the first minute or so may be slightly different to what's occurring over 5 minutes and 15 and 20 minutes as the reflexes and responses occur.
Thanks, Mike. Again, very good answer. And now moving on to the last part of the bedside tutorial. We are going through the number of infusions that patient is on, and we notice that patient is on Midazolam infusion. And the question is, what is the mechanism of action of Midazolam? And what are the kind of some of the key pharmacokinetic properties of Midazolam in ICU patients?
Yeah, okay. Well, that's a good one. So, I mean, and whenever you come up to a bedside, you'll see that there's often 10 or 15 drugs running in a patient. And a lot of our level 2 drugs are what we would call drugs that are used every day. And I think it's still fair to say that Medazolam is used in many ICUs in many patients every day. So Midazolam is a imidazolol derivative. It's a benzodiazepine. So it augments the activity of GABA receptors, promoting an increase in chloride conductance, and depression of the central nervous system is its primary effect. So we use it as a sedative or an anxiolytic, occasionally anti-epileptic drug, has some mild antiemetic properties, usually as an anxiolytic level. And when given intrathecally, it's an analgesic. So it's got quite wide properties. I mean, we don't talk about it being an analgesic as an IV infusion because it probably doesn't have that same effect. But when you give it intrathecally, it has analgesic effect. So it's a sedative agent, an anxiolytic. So we use it to reduce the memory of intensive care. One of the downsides of that change to the central nervous system activity is an increased risk of delirium when you're exposed to it for a prolonged period of time, which may be a function of receptor deactivation or uncoupling, or it may simply be a function of accumulation of neurotoxic elements of the drug. We're not really sure, but certainly the association with delirium is quite strong. So it's used as an intravenous infusion because it has a short intravascular half-life. It's got quite a high rate of clearance, initially with bolus dosing from redistribution, but then it's fairly efficiently cleared by the liver. So you have a short half-life, and we facilitate that in ICU because when we turn the Midazolam off, we know that patients will have a relatively predictable wake-up time, which may be, of the order of hours, and that's okay. So it's a drug that's given as usually as a loading dose, although we don't tend to always do that in intensive care unless we're using it as an induction agent for intubation as well, often with or without some coexistent opiate and muscle relaxant. But the dose for seizures would be aliquots of 0.1 to 0.2 milligram per kilogram. So you'd be looking at 5 or 10 milligrams for an adult patient, assuming they've got the cardiovascular reserve to tolerate that sort of dose. If they didn't, you might reduce the dose further and give smaller amounts, but you creep up on them until you've given an overall dose of about 0.5 milligram per kilogram, which would be the loading dose of Midazolam. And then we would run a continuous infusion, and we talk about mics per kilo per hour of Midazolam or minute. 50 mics per kilo per hour or a mic per kilo per minute of that order would be a starting dose, and you've got a range at which you can use it depending on what you're trying to titrate to effect, whether it's a sedation score, the presence or absence of observable electrical activity on an EEG and or motor seizures, or whether you're simply wanting them to appear anxiolized, you titrate the drug to effect. We could talk about the pharmacokinetic properties of it. So it's got fairly high protein binding, well over 90%. Its volume of distribution varies in the textbook, but it's of the order of 1 to 3 litres per kilo, which is, total body water or a bit more, which you would expect for a fairly lipid-soluble drug. Its redistribution half-life is about 3 minutes, and then its steady state is 30 minutes. So you've got that sort of biphasic redistribution after its bolus. And then it's predominantly hepatically metabolized. It's oxidized and then glucuronidated, which means that it has a sugar moiety attached to it, which renders its metabolites water soluble and they're excreted in the kidney. And some of those metabolites have some mild activity, not as predictably as the morphine metabolites, but they do have some prolonged activity. So you'll get a little bit of ongoing benzodiazepine effect after midazolam's been metabolized. And those metabolites do accumulate to a degree in renal failure, and that may well prolong its effect in renal impairment. We talk about effects and unwanted effects of midazolam. So the effects are the central nervous system depression, which would include sympathetic nervous system reduction. So you often get a reduction in heart rate and blood pressure. There's a reduction in ventilation, and a significant number of patients will become apneic on the sort of loading doses that we've talked about already. There's some diminished splanchnic blood flow, renal and hepatic with midazolam. And then the other sort of CNS effects we've talked about with the reduction in activity, there is some tachyphylaxis to that over time and tolerance. So often your doses have to be increased. And there's also withdrawal phenomenon. So if you've been on benzodiazepines for a long period of time and midazolam, you can have withdrawal. That's more common in children. I'm not exactly sure how common it is in adults, but we certainly see it in children where they have a withdrawal syndrome when midazolam's stopped. And that sort of overlaps with the delirium phenomenon that we are increasingly recognised in children. And I know it's well recognised in adults. So that's some of the unwanted CNS effects. And like most drugs, there's always the sort of nausea and vomiting. Rarely you can get anaphylaxis to midazolam, but that's not particularly common. But the exaggerated effects on the respiratory system in terms of apnea or on the cardiac system in terms of hypotension would be anticipated and would be more likely in a patient with underlying cardiorespiratory or central nervous system abnormalities.
Thanks, Mike. So obviously, Mike covered pharmacokinetics, but also he covered the pharmacodynamics of midazolam, which is always quite handy. So I guess this is a great demonstration of how you can just simply, with one patient in ICU, can practice so many things around primary exam preparation. And that easily covers like 3 big questions, maybe a Viva question or maybe a written question. And I think that's a great way of practicing in your day-to-day life. So it doesn't need to be a kind of dedicated time for preparation of primary. You can do it every day at bedside. And as Mike said, just ask your consultant to choose one patient and ask 2 or 3 questions at that patient.
And the other thing is that you can then say, well, why are we using midazolam? Why not propofol? And then you can have a discussion about a compare and contrast. And it might be for this particular patient or the patients in general. So you can tailor your discussion at the bedside around the primary syllabus without even knowing it. And it makes it very easy. So similarly, if you had a patient who had renal impairment, why are we using fentanyl and not morphine? Or if we've got significant hepatic dysfunction, are we going to stay with midazolam or are we going to transition to something else? Or why aren't we using dexmedetomidine here? What are the pros and cons of using that drug in this situation? So just having a discussion that's informed by the patient who's in front of you enables you to learn your primary syllabus passively, because you're just answering questions, and the consultants are just answering your questions based on experience, and they don't have to be primary examiners. And often experienced intensive care physicians will say, oh no, I can't teach you the primary stuff, I haven't done a primary, or it's been too long. But in fact, they're at the bedside every day and they make very, very informed decisions about drug selection, ventilator selection, monitoring choices, all based on the primary syllabus, even if they don't know it. And having a discussion with the consultant about why he's chosen one drug over another is an excellent way to get an informed discussion about particularly pharmacokinetic and pharmacodynamic properties of drugs, which you may not be aware of. And it adds into the complexity, because if you've got a septic patient like this with pneumonia, there's a whole lot of changes that occur in that patient in terms of volumes of distribution, renal handling of drugs that are important, and that can easily inform your learning for the primary. And it's all just passive, because you're just having a discussion at the bedside and you walk away remembering that sick bloke in bed 7 who had this problem. And that's where I learn all my midazolam pharmacology, because I can hang it on that hook.
Yeah, that's correct. And I think it's very easy way to practice your primary exam preparation. So thanks, Mike. So obviously, so far I was asking you questions and enjoying. And now it's your time to ask me a question.
Well, can I ask you anything?
Yeah, sure.
So it's always good to, if your consultant asks you a question on the ward round, the best thing to do is to just quickly ask them a question back to see if you can get out of the fire zone sometimes. But I've got a joke for you, Swapnil, and we're starting to scrape the barrel here. But why did the computer go to the doctor?
I liked your scrapping the barrel already, because this is only our 4th episode and you are already at the barrel.
I'm already struggling. Yes. Struggling. Well, that's because Maddie used all the good ones up. You see.
Okay, so why computer goes to the doctor? Because doctor has got extra brain.
Oh, but actually, because the computer thought it might have a terminal illness.
Okay,
I'm so sorry.
No.
I'm so sorry.
That's a good dad joke. So
yeah. No. All of my jokes are wearing woolly jumpers, my friend. They're all dad jokes.
No, well done, Mike. So thanks, folks. Thanks for listening and thanks for your valuable time, Mike. So we'll be back in months' time with another clinical scenario where we'll walk you through another kind of similar pattern. And if you have any feedback, please send us your feedback, which will be very valuable to modify these episodes. See you in next month's time.